for this very hearty and loving introduction, dear friends. What I'm going to speak today is some new facts. We'll discuss the CVD in diabetics, the Indian scenario, and what are the challenges and opportunities. Dear friends, I will present three facts which are important for today's discussion. Number one, the disease burden study, global study, showed that the age standardized CVD rates, CVD death rate for 100,000 population, 1 lakh population in India is about 272, whereas the world average is 235, meaning thereby that we have more CVD deaths. Number two, this CVD in Indians, all of us know, occurs at least 1 decade earlier. Third and most important thing, that if you have 22% in diabetics having CVD, we have non-diabetics about 11%, meaning thereby that it's a great problem in our population. This is a very important study. This is regarding the state level variation in the age adjusted rates of IHD and stroke. To make a long story short, this study done by Dr. Prabhakaran from PHFI, I just like you to read the bottom line. Now, we have substantial variation in the burden of IHD and stroke and mortality variation also. But if you look at this, between 1990 and 2016, when this study was called for, that is for about 26 years, it was found that the rates of CVD and the mortality in CVD has gone higher, whereas the mortality and the prevalence of stroke has remained constant, meaning thereby that the vascular risk is more in form of IHD than stroke, and it is more so in diabetics. I'll show in the next slide. Dear friends, this is again from the Dr. Prabhakaran, my classmate from the PHFI, who has shown that if you look at the various things, I'll again go to the bottom cartoon. If you find that in Indians, we have diabetes at a lower body mass index compared to, say, Americans. Number two, we have same prevalence of CVD despite major differences in the BMI. Our BMI is low, but CVD rates are same or even higher. We have, of course, low intake of fiber, and we take a lot of whole grain. But the bottom line is that as a race, we are more prone for the cardiovascular complications. Dear friend, this is a funnel chart, and this is a new chart which I like to show it to you. This is a meta-analysis which shows that in type 2 diabetes mellitus in India, the prevalence of CVD, heart disease, cardiovascular, not the vascular as a whole, the heart disease is about 21.1%. In the forest plot, if you see the black one, the forest plot, you will find, anyway, in the forest plot, you will find that the middle point shows the prevalence of CVD in each study, and the rhombic figure shows the prevalence of cardiovascular disease in patients in type 2 diabetes entire study, and the prevalence of heart disease in diabetics is much more in Indian population. This is a very beautiful data, which again new data, which shows about the duration of diabetes and the prevalence of CVD. Now, this study assessed the CVD risk over 10 years of diabetes duration. It showed that the duration as it increases, there's a linear increase in the CVD complication. But what is most important, even after 5 to 10 years, the CVD risk in diabetes increases linearly much more than other diseases. Therefore, when we get diabetes at a younger age, and now we are living longer, the cardiac disease becomes very, very important. Dear friends, this is in the newly diagnosed type 2 diabetics. As you know, when you diagnose type 2 diabetics, there is already some comorbidity. It shows that if you take between males and females, what is the differential? You will find that that in the females, the CV risk is little lower. You find in the hypertensives, the CVD risk is very high, and we have high level of hypertension in diabetes. In the persons who smoke, it is still higher. obese, it is still higher. And most importantly, people who have renal disease, their developing CVD is great. Therefore, we are as a population are very prone, even at the time of diagnosis, the Q risk score in our population in males is higher than the females. Smokers having highest CV risk, followed by CKD, stage 3 to stage 5, hypertension, obesity, and of course male gender. This again shows that the CV risk in the newly diagnosed type 2 diabetes is propensely increases, and it is very important to know that it strongly increases with the age, and after 35 years of age, the males have significantly more risk compared to the females till the menopause. Not only the CAD, if you look at the heart failure, the diabetics also have a greater degree of heart failure because of hyperglycemia, IR, hyperuricemia, and many other things. And it has been also shown the atherosclerosis in Indians because of IR, because of lack of insulin signaling proper, is also higher. And you find the hypertense Indian population is also higher, which addresses the stress of oxidation, rash system, insulin resistance, simple nervous system, and adipokines. So therefore, if a diabetic develops proteinuria, please, we all know about it, it leads to hyperlipidemia, and this leads to CAD. Dear friends, there is a greater degree of dyslipidemia in our diabetic population. Adipose tissues release free fatty acids, and this free fatty acids increases the peripheral insulin resistance. They are further entrapped in the liver, giving rise to triglyceridemia in the hepatic cells, and therefore the dyslipidemia in diabetics, we find there is triglyceride-rich LDL molecules, and they are the forerunner of the heart attacks. Now, if you look at the lipid abnormalities in type 1 diabetes, it is similar to general population if the blood glucose is controlled, but our main problem type 2 diabetics. In type 2 diabetics, the apoprotein B, LDL, LDL small dense proteins and other fractions are very high, and if there is a poor glycemic control, still higher. Therefore, lipids are very important in our country to give rise to the diabetic heart disease and coronary disease. Dear friends, there is a disease called primary specific heart muscle disease. Without hypertension, without rheumatic heart disease, without any known cause, they develop heart failure. We call it primary specific heart muscle disease. This is a study which was done in 2020. It has shown that the LV mass index is higher in diabetics due to interrelease of the cytokines, and they produce the heart failure and the other cardiac problem. Now, if you look at the diabetic dysfunction at the cardiac system, what we call whatever the REF or PEF, or look at the various types of dysfunction, we find there is increased cardiac lipids, the cardiac steatosis, and the homeostasis of the calcium is altered in the diabetic muscles, so that the resistance to insulin, and they produce primary specific heart muscle disease, giving rise to the heart failure. Dear friends, there are some genes which variants increase the risk of diabetes and CVD as a whole. There is a new finding. The genes which increases are TCF7, which is very common in our population, the FACTR1, HMGA1, and the other genes are given there, and these genes are forerunners of diabetes mellitus and CVD. The Indian population, the entire genetics has not yet been worked out. Now, what we should do, what are the challenges, what we should do, next 10 minutes I'll spend on that. Now, I'm very pertinent to say that we are not doing what is available with us as the low-hanging fruit. Dear friend, the statin use in the I7 India study we found was hardly 21%. Wherever we say the statins are like, they say statins is the second aspirin of the modern world, statins are used only in 20% of the patients. Number two, the hypertension is controlled in about 25 to 26, 24% cases in diabetics. The advice regarding physical activity, diet, salt, etc. are not usually given. I'll draw to two things to say that the addressing the use of lifestyle and statins or antihypertensives, the USA has brought down the cardiac problem. Similar thing also had happened in the Swedish national study, I did not put the slides, I have only put the new slides which are beyond 2020. This study, all of you know, the Swedish national study showed that the heart attacks are coming down. But in India, in contradistinction, we are increasing because our statin use is absolutely low, BP control is not as perfect, and also lifestyle. Three things: eating less, walking more, sleeping well. Of course, stress-free is not in our hands, but these are the three things that we must do to keep it at abeyance. So the things that is most important is to look for a multifactorial treatment. Now, first we must have an anthropometric and clinical assessment. Therefore, we must screen for the BMI and screen for the waist circumference. All of you heard Anup recently in the Indian obesity data, the waist circumference has been again coming back. Even though said should not touch the buttocks, take out the waist circumference, it is coming back because it's very important for the cardiac risk marker. You should do clinical assessment like medical assessment, obesity assessment, diabetes assessment, physical examination, review of all the systems, and clinical laboratory test. As all of us know, this is not the lack of knowledge, the lack of, its manifestation in our clinical practice important. Step 2, we must assess the risk and discuss with the patient and the family the goals we want to achieve. So we must ask the patient and explain to them what is their cardiometabolic risk. We have so many scores. UK PDS is giving 10 scores. You just use Q score for the cardiometabolic assessment and discuss with him the treatment goals, and there is a risk specific algorithm. If lipid is high, what to do, BP is high, what to do. So this we discuss with them. I must tell you, when you tell the patient about the heart, they are more receptive. We tell all our patients, possibly Rajiv said about the Mediterranean diet and the olive oil. It costs about 1100 today per liter, whereas the fortune oil is about 200. People don't listen to us. Cardiologists, once they have some chest pain, they say olive oil, they all change to olive oil. So my belief is that if you tell the patient very significantly that these are the diet and the physical, the lifestyle that you must follow for your heart, they will follow better. Number 2, and you must use treatment using multiple algorithms like lifestyle algorithm, I'll come to that, obesity algorithm, pre-diabetes to diabetes conversion algorithm, and the atherosclerotic cardiovascular disease and the CHF algorithm. So dear friends, this is the modern management which has come into existence today. So these 4 algorithms I'll describe. That's the end of my talk. Now, dear friends, now coming to the lifestyle therapy algorithm. As I rightly said, I meant that there's a lot of emphasis in this meeting on simple things. I just pointed out lot of things which are inexpensive. We cannot ever forget to carry our legs. So the lifestyle therapy algorithms. Now nutrition. Please do a individual planning. Reduce calorie. Now daily about 500 deficit. Meal plan including whatever, low carb, low fat, as far as possible high protein. I believe in high vegetarian protein, but I have no bias towards non-vegetarians. And of course, there are so many approaches to prevent hypertension, including salt. DAS is not necessary, or ordinary approach is good enough. Meal replacement, very low calorie diet, etc. for the nutrition. Physical activity is about more than 150 minutes per week walk. Now, we do not say in Indian patients 5 days, we tell 7 out of 7 days. And it is very important to do that. Some resistance exercises for the major muscle groups. And we have just now published a study that if you do exercise in diabetics, your sarcopenia is not there. Otherwise, you find all the diabetes are developing the legs which are narrow, the hand which are narrow. Of course, at that age they don't need, but in muscles. But you must have a body like the film actors Salman or whatever. You must have, and that is only possible if you do regular physical activity. Reduce sedentary behavior, and also you must have a program which suits you. And if possible, you have some technology. Cheap technology is the wearable step meter. Behavioral support is very important. I'm very passionate to tell you. I'll be also speaking in the other room. Vijay has asked me that you must have this support for the behavior change. Like you tell them that you have to monitor blood glucose. It will now the price of the strips. Some strips have come down. It's about 10 rupees. Some strips remain little high, but you decide which strip to use. Food intake, exercise, weight control and blood glucose monitoring. There is very important that we should have talking to the patient ourselves, nothing like ourselves or our staff, and also try to tell them remain stress-free, easily said than done, and very important to evaluate and see that they are happy. Now, we have a term today called glycemic happiness. You have to do that. You know, Abdul Kalam ji, he said once when I was in Bangalore with him, he said diabetes is not a disease, a syndrome, because when 25% people have, it is a syndrome, it can be disease. So why to worry about it? You do, take it as a blessing. It is there to control your life, to plan your life. So that's how we should approach it and motivate them. Number two, of course, smoking cessation. I don't see the patients who smoke. At least if I see them behind my, it's very important to smoke cessation. And sleep is very important. At least 7 to 8 hours sleep is very important for the lifestyle algorithm. Obesity algorithm, normal weight without complication is our important objective. Eat healthy, act healthy, and spread the virtue of health education. We have started a new system called the health education program. This is very important. Now, in the stage 0, when they have overweight or obese, but they do not have any complication, that time you must institute a very aggressive lifestyle program and bring down the BMI much below 27. Anybody above 27 must be admitted for a great lifestyle program. Stage 1, overweight or obese with mild or moderate complications, there you must give lifestyle program and medications. Medication simple, metformin. It reduces weight, at least weight neutral. The DPP-4 price has come down. There is also weight neutral. And the complication treat. When they're overweight, obese with more complications, then you have to decide what medication to give or how to approach their obesity. Now for the dyslipidemia, it is very important to have the goal setting. LDL goal less than 100, triglyceride 150 for the high risk, very high 70, extreme risk 55. I have taken from the Indian guideline, so that must be adhered to. Now CVD risk factor algorithm for the hypertension, use the drugs which are very simple like ACE inhibitors, ARB or the CCB or the beta blocker. And it's a combination therapy, and if it is not coming under control for a month, add the next drug. Now there are so many treatment options for the hypertension, starting with lifestyle, sodium reduction, physical activity, weight loss, sleep apnea, taking care, steps, and also the impact with the newer drugs. So hypertension has to be managed, so lower the blood pressure by the synergistic drugs. Now for the diabetic cardiomyopathy, the drugs are nothing great, same ACE inhibitors, ARBs, the beta blockers, and take care of the diabetes control. Now the drugs which have got definite cardiovascular benefits and has been addressed by the EASD and ADA are these drugs. The prices have come down because they are off patent. The prices have come down, it's still coming down. Today we get DAPA at the price of 4 rupees. I'm not advocating for a drug, sir, but I'm just telling the price compared to previous years has come down. Some have not brought it down, they will be falling in line. So wherever necessary, you can think of using this drug. The issue is there's a lot of cardiovascular benefit. And if the patient is in the risk category 2 and 3, you must be used. Now there are GLP analogs which are also going off patent. The liraglutide has gone off patent. We have taken the patent out last week, so it will be available in the class now. We also have the drugs like metformin, which can take care of the weight, the anti-diabetic drugs, and the targeted blood pressure control we know, but we don't achieve it. Lipid control achieved goals are given here. Now, what are the problems? The last 1 minute. Developing country like India, we face a huge burden of diabetes and its complication. Now we have socioeconomic factors, so we must be awake to it. Problem with the medical infrastructure. We have inadequate follow-up in monitoring, and we have a proper absence of care. The financial burden has to be looked into. It is government duty to give free treatment for everybody. Adherence to guideline must be there. And the strong correlation between diabetes and the CVD must be known to everybody. Health condition, dyslipidemia, hypertension, obesity, and other risk factors must be addressed. Now, there should be the prime reason of NCD rise is nutrition, lifestyle, therefore higher body fat, abdominal fat, liver and pancreatic fat, any ectopic fat has to be controlled. Conversion of pre-diabetes to diabetes must be checked. And last slide is that the huge number of patients with diabetes and with complications increase the morbidity and mortality and pose substantial economic problem which we must be aware to and take care of. Thank you very much for a kind hearing.